Urolithiasis is the presence of calculi within the urinary tract, from the kidney to the urethra. In the United States, the lifetime prevalence of nephrolithiasis is approximately 10% in males and females. Peak incidence occurs in the 4th to 6th decade of life. Stone prevalence is increasing, and females now have stones almost as often as males. And between 1 and 2 million emergency department visits annually are due to kidney stones and renal colic. Additionally, the incidence of symptomatic nephrolithiasis is greatest during the summer as a result of increased temperature with an increased risk of dehydration and urinary concentration. About 80% of patients with nephrolithiasis form calcium stones, most of which are composed primarily of calcium oxalate. Basically, stone formation occurs when normally soluble material, i.e. the calcium or oxalate, supersaturates the urine and begins the process of crystal formation. The risk of nephrolithiasis is influenced by urine composition, which can be affected by certain diseases and patient habits. For calcium oxalate stones, urinary risk factors include higher urine calcium and higher urine oxalate, whereas dietary risk factors include lower calcium intake and higher oxalate intake. Foods high in oxalate include beans, beer, beets, berries, chocolate, coffee, and dark green vegetables such as spinach. Anatomic risk factors include medullary sponge kidney as well as horseshoe kidney. If a patient has reported a history of kidney stones, this is something to pay attention to because the rate of stone recurrence is 10 to 30% at 3 to 5 years among patients with idiopathic calcium oxalate stones. Additionally, patients with a family history of stones have an increased risk of nephrolithiasis as well. Stone disease is more common in individuals with diabetes, obesity, gout, and hypertension. Even excessive physical exercise, such as marathon running, may increase crystalluria. A persistently acidic urine, meaning a pH less than or equal to 5.5, promotes uric acid precipitation and leads to the formation of uric acid stones. Acidic urine is seen in chronic diarrheal states. Struvite stones only form in patients with an upper urinary tract infection due to a urease-producing organism such as Proteus or Klebsiella. Classic symptoms of nephrolithiasis are uncommon. However, the diagnosis is suggested in a patient with recurrent urinary tract infections, mild flank pain, or hematuria, who has a persistently alkaline urine, which means a pH greater than 7, often with ammonium magnesium phosphate crystals in the urine sediment. Patients who form uric acid stones frequently describe passing gravel, but uric acid stones can also produce acute obstruction. Symptoms may develop when stones initially pass from the renal pelvis into the ureter. Pain is the most common symptom and varies from a mild and barely noticeable ache to discomfort that is so intense that it requires parenteral analgesics. The pain typically waxes and wanes in severity and develops in waves or paroxysms. Paroxysms of severe pain usually last 20 to 60 minutes when they occur. This pain is thought to occur primarily from urinary obstruction with distension of the renal capsule. Consequently, pain due to a kidney stone typically resolves quickly after passage of the stone. The site of obstruction determines the location of the pain. Upper ureteral or renal pelvic obstruction leads to flank pain or flank tenderness, whereas lower ureteral obstruction causes pain that may radiate to the ipsilateral testicle or labium. The location of the pain may change as the stone migrates. This is why your history taking is so important. So the OPQRST, or onset, provocation, palliation, quality, radiation, severity, and timing. Nausea, vomiting, and dysuria may also be